In Part 6 of GI disorders, we're going to discuss two issues that affect our little babies, usually less than 6 months of age. The first is pyloric stenosis, and what this is the pyloric muscle, that is the outlet to the stomach, is hypertrophied, and it's very thick, and the lumen itself is narrow. Therefore, as the baby drinks milk or formula and the stomach distends, the pylorus is so tight it can't be propelled into the jejunum. As a result of the increased pressure within the stomach, the baby ends up emptying the stomach contents by vomiting in a projectile manner, which means it's not just a little spit up on your shoulder. They're vomiting about 3 feet behind you. We don't really know what the etiology of this disorder is, but we do know that it affects males more than females, and it's more common in our preterm babies. We usually diagnose it within the first few weeks of life, and the latest it would occur is usually 6 or 8 weeks. So here's a nice picture of what a pyloric stenosis would look like. On the top left, you see the normal pylorus. The muscle itself isn't that big, but compare that to the bottom. That one is really, it looks like it's 10 times bigger. And then when you look at the lumen, it's like the size of a pencil in compared to the normal one. And then there's additional pictures that are on the right, so if you have a color preference, it just makes it a little bit easier to see. Here's a picture of a baby who has a distended abdomen because of a pyloric stenosis. And what you should also notice is just to the right of his little belly button, you see something that almost looks the size of maybe a small orange, one of those little cuties. And what that is the olive sign, and it's distension of the stomach. And then if we were to compress it, we would feel this firmness at the bottom of the stomach. When we do the assessment, this child has projectile vomiting, so 2 to 4 feet behind you. And when they're on their backs, they can vomit 1 foot. That's quite forceful. This usually will happen right after feeds. What we're going to see is partially digested foods. Now, these babies are on formula or breast milk, so the partially digested food is going to be the formula that's curdled. Breast milk will come out pretty much the way it went in. There's no bile in it because it's never gotten out of the stomach. It hasn't been in there long enough. And the other thing is the baby gobble to eat, and then they vomit, and of course then they're hungry again. And so it's a vicious cycle. But what ends up happening due to repeated vomiting is this child has weight loss, and they have a lot of fluid and electrolyte imbalance, acid-base balance, so they're dehydrated and they develop metabolic alkalosis because they're throwing up all the hydrogen ions from their stomach. And so that olive-shaped mass can be felt in the right epigastrum. And if you go back to that baby, you see that there's the big bulge in the stomach and it's more on the left side of the abdomen, but that olive would be on the right. So we diagnose this by having the baby do a barium swallow, and we'll see a delayed gastric emptying, and then what they'll see is this formula is trying to go, or the barium is trying to get through that pylorus. It just looks like a little string. The baby is placed NPO, and we'll send off a chemistry panel to look at the electrolytes, and we'll have to replace them prior to going to surgery. Hopefully this kid hasn't come in to be so dehydrated and sick that we have to put them in ICU. Usually we can perk them up for a couple of days on the floor. We'll put down an NG tube to help with decompression of the stomach, and when the baby is completely stabilized and it's safe to put them under anesthesia, then they'll go to the operating room. It's a very quick procedure, 15 to 30 minutes, they're done, and basically what they're doing is they're just cutting it. They do a laparoscopic procedure in the right upper quadrant, and they make an incision through the muscle down to the submucosa, and that's it. They come back up to the floor. They'll have an NG tube for a very short time, just long enough to decompress the stomach. And then we start feeding them again, and it's a slow and gradual progression. So they'll advance the feedings by between 3 and 5 cc's per feed until the baby is up to where it should be based on its age. And as the oral fluids go up, the IV fluids go down. There is still going to be some post-op vomiting, and this is normal. The stomach is figuring out how to work. So we need to let the parents know that this is common and that it is going to go away, because after all, they just signed on the dotted line for a surgical procedure thinking that, oh yay, it's going to be done. And oh my gosh, here's my kid still throwing up. But it's not going to be that forceful projectile. It's going to be more of that spitting up. So position the baby upright and turn them a little bit to their right side. Pain is minimal, so we usually just give a little Tylenol if necessary. So make sure that you use the flax scale. And that's it on pyloric stenosis. Now the next thing that can happen, and it's totally unrelated to pyloric stenosis, is what we call intussusception. And that's a lot of S's. What happens here is a part of the intestine slides over another part. So it's like a big tunnel. It tunnels into itself, and you can see that on the picture. And what ends up happening is it cuts out some blood supply. There's a lot of swelling. It happens in children less than 2 years of age, but it usually starts at about 6 months of age. And so the history that the parents are going to come in, what will bring them in is when the baby has the bloody stools, and we call it currant jelly because it's mucousy and it's got the color of currants. That's what's going to bring the parents in. But then when you start asking the questions, they'll be saying the baby just starts screaming bloody murder. They're crying. I can't console them. It's lasting about 15, 20 minutes, and then they stop and they're perfectly fine. And then 15 to 20 minutes later, they're doing it all over again. And as this recurs over and over again, now the baby's not only screaming uncontrollably and inconsolably, they're bringing their knees up to their chest to try and get some relief of the abdominal pain that they're having. So what do we do about it? Well, we used to consider intussusception as a surgical emergency, but now we do medical therapy before surgery. So you will initiate an IV, make the baby NPO, and then they might insert an NG tube because they get to have a lot of gastric distension from this belly pain and the crying. We're going to send this child to radiology, and they're going to have either a barium or an air contrast enema. And usually it's barium because it's both diagnostic and therapeutic. And so they insert the barium into the rectum in the hopes that the hydrostatic pressure of this fluid is going to force that part of the intestine to straighten itself out. And if it works, great. All of a sudden the baby is a happy camper, and we're going to keep the child in and make sure that they pass the barium, and then they get to go home. But if it doesn't work, or if it works only temporarily and then recurs, then what they're going to do is admit the child. If they've gone home or if it's in the hospital, we're going to get them ready for the OR, and they're going to do a bowel resection. So just take a look at that picture here, and you can see all of the edema that occurs with the gut as it is pushed inside another one. And so it starts becoming edematous, and it oozes, and it starts bleeding, and it's very painful because they're actually necrosing a little part of that gut. So this ends the section about pyloric stenosis and intussusception.